Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. COVID-19 has changed many aspects of life, including routines like going to the doctor. Mayo Clinic has navigated the COVID-19 pandemic and has safely reopened the practice to meet the needs of the patients, including my area of expertise, orthopedic surgery. Joining us to discuss practice medicine during the pandemic is my colleague, Mayo Clinic orthopedic surgeon, Dr. Noelle Larson. Dr. Larson, welcome to the program.
Thank you, Dr. Kakar. It's a pleasure to be here.
So Dr. Larson, can you tell us how Mayo Clinic, and in particular the Department of Orthopedic Surgery, has gone about safely reopening the practice so we can take care of our patients?
Absolutely. Well, as you know, patient safety and appropriate hygiene practices have always been a priority at Mayo, and it's one thing I enjoy about working here. It's a clean environment, but certainly there are additional challenges in the face of COVID. And after we had a pause in our elective practice, it was a big effort to bring surgeons and patients and staff back in a method that would be appropriate and safe for everyone. So we have infection control doctors and nurses working all the time. In addition to that, Mayo created a new team called the Strategic Management and Resource Team, which has a nice acronym of SMART. But basically the idea was to disseminate best practices throughout the institution. So the first line efforts we undertook were universal mask wear. So everyone on the campus wears masks, eye protection, and then there's higher level of use of personal protective equipment, of course, for patients who are known or unknown COVID status and for high risk type procedures. In addition, we implemented a limited visitor policy, which I think has been challenging for all of us. We're used to bringing our closest trusted allies with us when we go to the doctor, and both for the pediatric and the adult practice, we are limiting the number of visitors just to try and reduce the number of exposures. All of our non-essential staff, many of them have been transitioned to work from home positions. So you will notice that the parking garages and the administrative areas of the campus are a little less crowded, again, trying to reduce the number of exposures to each other. In addition to this, we have social distancing practices and use of eye protection. We have implemented higher level of cleaning practices such that all surfaces are cleaned in the patient areas, every hour basically. So we've put forth a lot of steps. It's unclear which ones are most successful, but I would say on the whole, the battery of precautions has been very successful at restarting our elective practice in a safe and productive manner.
Yeah, you mentioned about the cleaning. I've just noticed, and I'm sure you have, in the outpatient practice setting, when you see a patient and the patient leaves, how the nurses and the attendants run in, they clean everything that's supposedly being touched by the patient, and they do it on every single patient, and it's like a pit crew. Is how my analogy is. They come in, they do it, they move on, and the new patient comes in, and as you're right, every surface. And I've been amazed how many different surfaces are touched, and yet they're all clean to the highest level of detail.
Yes, and we're using a variety of facilities approved cleaners, but basically the light switches, the door handle, the sink, the computer, the seats, the tables, again, everything that someone might come in contact with is being disinfected. And additionally, in the lobbies, everything is being disinfected. We've implemented, elevator precautions to limit the number of individuals on the elevator at one time. But interestingly, as we learn more and more about COVID, it does seem to be something spread through the air and through droplets. So the masking, I think, is probably the primary move that has really been essential. And I think it's challenging, particularly I have a pediatric orthopedic practice, so how do you get a 2-year-old to wear a mask, right? But on the whole, I've been very impressed by our providers and our staff and our patients and their ability to wear a mask and willingness to wear a mask. And I would say it's a safe thing to do. You hear things about, limited oxygen capacity, but for most individuals, wearing a mask is extremely safe. Children over 2, we think it's safe to do. Most people can do well with a mask, and I think that's probably been the one step that has been most helpful as far as preventing transmission.
So as you said, as a pediatric orthopedic surgeon, not only are you taking care of the child, but also the family. So how have you negotiated that and your colleagues in the area of pediatrics?
We've been doing more virtual medicine visits, and I have actually learned a lot to see the child in their home and their natural environment, having them show me their room and their playthings, or seeing them out in their backyard running around. I mean, that's like the ultimate post-operative visit, right? To see the child in the environment. So we're doing more virtual visits, at which point you can have any number of family members. And in fact, we've been able to do three-way virtual visits where we
Mm.
have one parent at work and another parent at home with the child and me, and we're able to discuss the medical problem. I think the physical exam is difficult with a virtual visit in some instances. I'd say it's been challenging for the important discussions. At one point, we were limiting it to one visitor, so having only one parent there and making important surgical decisions about a child's orthopedic future. That is challenging. We've been able, at least in certain areas, to open it up to two visitors, and that has been much more helpful. And then I'd say the other challenging area for me is when I've been treating a child for 5 or 6 years and then they turn 18. And for adults, particularly for adults in the hospital, the visitor policy is a little stricter. We are just allowing one visitor from 8 a.m. to 6 p.m. And that's hard for an 18-year-old who just turned 18 and yesterday was a 17-year-old, and now they only get a parent there during the day with them. But for the most part, we've had a lot of discussions. Again, the patients and families have been very understanding, and all these steps we are just putting into place temporarily to protect them and to protect ourselves. So, but it's an unusual situation. Never in a million years would I think I'd be limiting the number of visitors for my patient who just had surgery. It's
No,
a
but
different step.
as you mentioned, you've worked creatively with the virtual visits, as you said, and seeing the patients at their home. And I think that's probably the most important for pediatric care, to actually see how the child interacts at home in their natural environment. You mentioned about the SMART team, and with the deluge of information that comes in on how COVID is changing, how do you stay abreast of all this information to ensure that there's safe practice here at Mayo Clinic?
Basically, I act as a conduit between the infection prevention committee and kind of the institutional leadership as far as the steps that different departments and different areas are taking to prevent COVID transmission. So as we have conference calls and in-person meetings, we have kind of walkthroughs where I walk through all the orthopedic spaces and look for areas of improvement as far as social distancing and mask wear. Um, but again, the model is orthopedics has picked one person to try and learn more about it, and then I filter the information and then present it to the department in meaningful aliquots, meaningful chunks of information that you can use, news you can use on a daily basis, and again, not subject the average orthopedic surgeon to all the in-depth details that maybe they don't need to know. So I think it's been a very effective model, and Mayo has used this for other major practice changes of teaching one person to then go out and share and hopefully improve the practice. Then also I learn from other divisions too. I mean, the challenges that pediatrics are facing may be similar to what internal medicine is facing or general surgery. And so the different practices can talk to each other and share ideas and then move those new protocols throughout the whole institution.
Well, as one of your partners, I can certainly thank you for all the information that you've disseminated to us in the little aliquots, as you said, for us to be able to distill it in our practice. And we truly are grateful for that. Now, Dr. Larson, obviously your area of expertise is in pediatric orthopedic surgery. Can you tell us any new advances in how you're treating your patients?
My primary area of interest is scoliosis, which is a side-to-side curvature of the spine. And for some reason, adolescents, as they hit their rapid growth spurt, the spine can start to grow in a curved fashion. And most of the time it's incidental, but about 1 in 3,000 children, it can become quite a severe deformity and eventually affect breathing later in life and certainly contribute to back pain. So for scoliosis, our treatment options have been relatively limited historically. We've had bracing, which works for moderate-sized curves. And then once the curves become quite severe, our primary go-to option has been a fusion. And I brought a model of a fusion. I know our viewers can't see, but it's rods and screws where we fuse the back, and it's very, very effective. It's been around since the 70s, but it does limit motion over the areas where the curve is. And there's concern about that being a cause for arthritis long term. And so a new technique was developed about 10 years ago, and we've been using it here for about 5 years. And it goes by a variety of names, but what the common is vertebral body tethering. And basically, instead of putting a solid rod in the back, we put a plastic cord, and this cord acts as an internal brace. So it holds the spine in a corrected position. If the child is still growing, we actually see the scoliosis reversing itself. So we've kind of reversed the vicious cycle of growth causing the curve, and we ask the cycle to work backwards, and the spine actually straightens as the child grows. As powerful as the fusion, but it does allow the child to retain motion, and we retain the normal joints in the spine, and at least it provides a stepping stone for the future. And obviously, if the tethering does not give enough correction, a fusion can be done later, potentially after the child has completed their high school and collegiate level sports. But it's been very rewarding. The recovery is a little faster, and it's definitely more physiologic.
That's what I was going to ask you about the patient. How did the patients do after this compared to traditional scoliosis?
The hospital course is about a day shorter. About half the children are on narcotics, whereas with the fusion surgery, most children are on narcotics for 1 to 2 weeks after the surgery. With the vertebral body tethering, the children are cleared to go back to most athletics at 6 weeks, whereas with the fusion, it's often 3 months to 6 months to return to, say, football or soccer. And clinic, we're doing a lot of studies right now. We're doing a motion analysis study, we're doing an MRI study, we're doing a health-related quality of life study. So at some point we'll have data, but it's so new, and our FDA approval just was achieved last August of 2019. So the research is a little bit in its infancy,
Mm-hmm.
but just anecdotally in clinic, I ask patients, how's your back feel? And they say it feels normal. And I haven't really had many fusion patients that say their back feels normal.
Sure.
So how do you capture that in a research study where we're working on doing that? But it does seem to preserve a little bit more mobility for these children who may have 80 or 90 years left to live.
Well, is there a particular patient where you feel the vertebral body tethering is more applicable to in terms of age or sex when they present, or the degree of curvature of the spine?
We're looking for curves that are between 40 and 65 degrees, which is moderate to severe. Curves that are flexible is preferable because it's not as powerful as the fusion, so the correction that we get is a little more limited. And then finally, we're looking for children that are still growing. Most of the data regarding the tethering procedure is in children who have at least 1 year of growth remaining. So in girls, that's typically 13 or younger, and boys, it's more like 15 or younger on average.
So when you put this tether in, do you leave it in, or do you take it out at another stage, or as the patient grows, you put a longer one in? What do you do?
The plan is to leave it in forever. And interestingly, as it's been presented to the FDA, that was a big decision. Do we present it as a two-stage procedure or a one-stage procedure? There is a higher revision rate, so there's a higher chance of a second surgery, probably somewhere around 10 to 20% at 2 years following the surgery. Whereas a fusion surgery, it's a lower chance of a second surgery, more like 5% at 5 years. So it's not perfect. It's a little less constrained and a little harder to control, but potentially more benefit.
Yeah, no, it's good to see how you're advancing the field as compared to traditional fusion procedures for these. Noelle, anything else you'd like to discuss?
No, it's really a pleasure to be here this morning, and tell everybody, please wear your mask.
Our thanks to Mayo Clinic orthopedic surgeon, Dr. Noelle Larson. Dr. Larson, thank you very much for joining us today.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.